Okay. Well, welcome everyone. We want to thank you for attending our webinar tonight on GlobeChek. Um, my name is Bill Mallon. I'm an ophthalmologist, and my partner over here, Adam Katz. We're two practicing ophthalmologists in Vero Beach, Florida. And we're looking forward to this evening talking to you about GlobeChek, introducing you to our technology. We're pleased to have our two guest lecturers tonight, Lema Alaswad and also Dr. Chad Albright. So we're going to run through just a brief history of GlobeChek and a little introduction. We'll have a video presentation. We'll have Dr. Alaswad and Dr. Albright speak to us about their experiences with GlobeChek. And then we'll hopefully have a robust question and answer period of time. So obviously, the world has changed, and so has eye care. And we feel like GlobeChek is transforming the way eye care is delivered. GlobeChek's interesting the way it started. It really was a kind of a casual conversation in the office here in Vero Beach. One day, Adam walked in my office and stuck his head in and said, "You know, this artificial intelligence and these eye exams are just going to be happening with robots." And I said, "Yeah, we're just going to get replaced." And then we started talking about it and said, "You know, nobody's doing anything like this. Why aren't we actually doing anything like this? There's a lack of eye care being delivered out there." And we sat down and we said, "You know what, we should do something like this." And we started kind of brainstorming about what should be in the ideal eye exam, how we could do this, and that ophthalmology really lent itself to this type of an exam. You can't really do an orthopedic exam without having a patient right there, but you certainly can do a lot with ophthalmology. A lot of what we do is imaging with fundus photos and OCTs and external photos, eye pressure. There's so much information that we get from testing. And then obviously a lot of what we do is looking at the patient, talking to the patient, coming up with plans. But the actual testing part of it lends itself very much to tele-eye care. And so we started on our journey, which is almost 7 years now. Initially, we came up with ideal testing that we would include in Globe, came up with a design, and we engaged with an engineering firm and started on something that we thought would be done in a year. And 7 years later, here we are. We've gone through really 4 renditions of the Globe. But our first year was spent developing the Globe. We found an engineering firm to build one. And at the end of the year, we decided we were going to take it out and see what people thought about it. Initially, we took it locally to a mall here in Vero Beach, planning on spending an afternoon just to see what people's reaction would be to the Globe. And 3 days later, where we had been scanning all day, every day, we decided that we may be onto something. People were drawn to it. Everybody in the mall came up to it and said, "What is this? You can do an eye exam with this?" Our first version was fairly slow, and it was a little bit clunky, but it worked, and we had a great experience with that. So we realized that the public liked it. We decided at that point to take it to the American Academy of Ophthalmology meeting in Chicago, having no idea whether our colleagues were going to look at us and laugh or whether they were going to find it interesting. And really, we were pleasantly surprised about the reaction. Most of our colleagues from around the world loved it, thought it was an amazing thing, and really were kind of drawn to it. We were actually recognized as one of the top 10 new technologies or new products at the Academy that year. So we came back really engaged with what we were doing, feeling we were onto something pretty special. And so we worked on that. And really our goal was to change the way eye care was delivered. We realized we would see people coming into our office on a regular basis with advanced glaucoma or macular degeneration or diabetic retinopathy, and not even know they had diabetes in the first place, or certainly have no idea that they had an eye problem, and thinking they may need eyeglasses because their vision was blurry and they had 0.9 cups and severe visual field loss. So we were frustrated by that. We thought, why are people going blind in the United States without access to care and not receiving care when 80% of blindness in this country is preventable? So we embarked on that journey, and we've been continuing. So again, looking at just what's happening out there, why are people not getting eye exams? Is it a lack of access? Is it money? Is it insurance? Is it fear of coming into an eye office and getting dilated, wasting a day at the missing a day at work? We look at statistics, average exam time between exams, 25 months. There's 61 million people in this country at risk for vision loss, and only 50% of those people have had an eye exam in the last year. We know that only 20% of diabetics with insurance who have a known diagnosis of diabetes are actually getting their yearly eye exams. So we're really missing something. School screenings, they miss 75% of children with vision problems. So we're not really doing the right thing for people. So we look at serious eye diseases, they're underdiagnosed. 25% of macular degeneration, 50% of diabetics are not receiving care, and 50% of glaucoma is undiagnosed, being that it's asymptomatic. So what do we do? GlobeChek, it's a comprehensive tele-eye care solution. In fact, it's the only one in the world that does what we do. There's been a lot of work in tele-eye care, telemedicine in general. If you look at what has been the state of telemedicine or tele-eye care, it's been fundus photography. That's been the standard of care for over 20 years. It was implemented back in around 2000 in the Indian Health Services. And most of this was done to reach out for diabetics. So we've really been missing the rest of the eye exam. So if we just focus solely on diabetics, which is obviously very important, we're missing all of the other causes of vision loss in this country, including just simple refractive errors. So what we do, we screen patients. We're able to do this in under 10 minutes. It's not intimidating for patients. They don't have to be dilated. There's no eye drops included. And now with COVID, they can do it in a very safe environment where they're socially distanced and essentially have no contact with anyone. We detect diseases. We pick out the 4 major causes of vision loss and many more. So we detect eye disease. Basically, the patient will have their GlobeChek exam done. They will leave. They'll have their data sent to a reading center where a GlobeChek physician will read the details of the exam, send a report to a patient. They then will log in and do a video chat with the patient, and that will then be billed. And what's changed massively over the last 6 months with COVID is the billing and reimbursement part of it. Typical GlobeChek exam, we do 11 tests in under 10 minutes. We do a fundus photograph, which has been, again, the standard of care for tele-eye care. We do an external photograph as well. That high-resolution photos, we've detected several skin cancers. You can see pterygiums, anything related to an eye, whether it be an entropy, ectropy, ptosis, traumaticulasis, thyroid ophthalmopathy. We do visual acuity, distance and near, so we're going to pick up presbyopia, myopia, hyperopia. We do an auto-refraction, so we get a general sense of what their glasses prescription would be. Corrected intraocular pressure based on corneal thickness. We do an OCT of the macula, OCT of the optic nerve, and an OCT of the anterior segment. Again, corneal pachymetry, topography, and then we have a cataract screening, which is quite effective at picking up changes in the ocular media. You can even pick up pseudophakia and posterior capsular fibrosis. Again, a GlobeChek sample report is there. That's what the patient receives once their GlobeChek scan's been read. Through the patient portal, they can share that with doctors as well. So what's happening? The current paradigm is shifting. Our standard, eye exams that we've done throughout history, we have a brick and mortar building. Patients will come to our office. We'll run them through stations and test them. They'll be dilated. They'll typically work their way through the office, seeing various technicians. And if you're very efficient, you're typically doing an eye exam in an hour. Many offices run 2 to 3 hours. And if you're going to certain universities, you may be there for 3, 4, or 5 hours, going there for a regular eye exam that you may see the doctor for 2 or 3 minutes. So not a very efficient use of patients' time or really a staff's time. If we look at where we are now, the new paradigm, we've got all of the same instruments we use in our office in a very small footprint. Our device is mobile. You can pretty much take it anywhere you want to go. There's no dilation required. There's no eye drops required. And it's going to give you a comprehensive eye exam, which has been shown through studies to be equivalent to a face-to-face exam. It's very easy to do this in the time of COVID. We're able to protect patients, give them the comfort that they're not being exposed and around a lot of people in a busy office. And again, the timing, less than 10 minutes. Patients are in and out. Patients who are working can come in and have this and go back to work. Don't have to miss a day of work being dilated. So we improve workflow, we expand the practice, and patients truly prefer this. When they've had it compared to a regular eye exam, we ask them, what would you like? Do you like GlobeChek? They love it. You can do 4 or 5 GlobeChek exams in the time that you're running a patient through your office. You're able to take this on a mobile. You can take it to a satellite anywhere you want to go. You don't need brick and mortar. You've got a mobile office, and it allows you to go anywhere. The care that you're delivering is unsurpassed. It's equivalent to a face-to-face exam, and many times you could consider this really to be superior to a regular eye exam because we're doing OCTs in the macula, optic nerve, things we wouldn't do during a routine eye exam. These patients are getting every test that we can do in our office. It's convenient, it's comprehensive. Again, it's very safe at this time, and you're picking up all kinds of eye diseases. So making eye care accessible was really at the core of what we wanted to do. We wanted to reach out and stop people from missing eye exams, making it just readily accessible, and making people understand the importance of eye care. We've developed really a turnkey platform that addresses not only the patient's needs, but also doctors' needs. So, this can be an add-on to your clinic. It's going to allow doctors to expand their practices and their footprints, reaching out to areas where they previously weren't able to go. Again, our vision is to eliminate the 80% of blindness that's preventable in the United States. So there are different levels to GlobeChek. We have our kiosk, which is kind of our main appeal. It's a turnkey tele-eye care solution, does all the testing we've talked about. We also have GlobeChek Virtual for those practices that aren't necessarily ready to get a Globe, but they're looking for an entry into tele-eye care. Most people don't know how to do tele-eye care. They're piecemealing it together with some kind of video solution. Their EMR may not be very capable of doing this. So GlobeChek's idea is to create a virtual GlobeChek for them, connecting all of the devices that you have in your current office, putting it into our reading center, allowing you to generate the reports, and having the video chat and the billing solution all in one. So we can pretty much integrate anybody's office with GlobeChek Virtual. The other benefit long-term and downstream is the GlobeChek network. Right now we have over 2,000 doctors as part of our network. Our goal is to have every ophthalmologist and optometrist in the world part of the network. This is an easily accessible database where patients can find doctors when they're in need of care. And that database will allow smooth transition between doctors. If you have a patient moving, it's always very difficult to find another doctor where they're moving to another town. Doctor, can you recommend somebody? Well, let me go to my GlobeChek app and find a GlobeChek doctor where you're moving. So the long-term GlobeChek network, we think, is going to have some significant power for patients and for physicians alike. So what are the drivers, the value? Well, you're getting 11 diagnostic tests. It's very comprehensive. Again, dilation free, less than 10 minutes. Scheduling tele-eye care consults gives you the flexibility. You can be on vacation, spend an hour or two doing some telemedicine visits, maybe sitting out on the beach, and your practice is still seeing patients while you're gone. Again, the efficiency, you can see 4 to 5 or more GlobeChek patients in the time that you're running one of your patients through the office in a traditional way. It's mobile. You get the mobile solution. You can take this anywhere. It essentially allows you to have a full eye care office in a kiosk. It's got a very small footprint. It's 5 feet by 5 feet. And it also fits through a 3-foot door by removing the shell. We are able to take the shell off, put it anywhere you want, and then put the shell back on. Again, the safety, we've talked about the COVID concerns in today's eye care world. We've got a great study to back up the validity of what we're doing, and multiple studies showing the equivalency of a tele-eye care visit to an in-person visit. And what's really changed with COVID is now the reimbursement. Telemedicine has really changed with COVID, probably knocked down a decade of barriers and reimbursement issues. Again, we started GlobeChek with not thinking that insurance was going to be involved in any of the reimbursement for many, many years down the road. We still felt there was a significant value add. So reimbursement has changed things, and it's made the average ophthalmologist and optometrist look at it now. All of us are creatures of habit. We're used to doing things based on insurance reimbursement. And this has opened those doors and made it easier for people to see the value. If we look at it, we can talk about preference. We've been using GlobeChek in our practice for several years. We now have two practicing ophthalmologists using it in other states, and typically the feedback has been really, pretty exciting. The patients love it. An awesome piece of technology. I think it was cool. Keep it. I applaud that wonderful device. It's wonderful. Quicker time, much better. Love no dilation. Amazing fast. Took care of everything. I had a local attorney who told me I saved him $600 by doing a tele-eye care visit with him. He didn't have to miss a couple hours of his practice. So there are real values that are, behind the obvious ones. And from a doctor's side, it's revolutionary, a huge time saver. The technology helps us streamline our practice more efficiently, with less chair time, provide great eye care with the depth of information that's important. Our mobile office offering is really awesome. You can take this Globe pretty much anywhere you want to go. We've got a generator, it's air conditioned, and essentially you can take your office anywhere you want it to be. You can take it leave it in the office, have patients come on board. It's wheelchair accessible, as you can see by the photo, or you offload it very easily. Take it into a mall, take it to a retirement community. Pretty much anywhere your imagination lets you take it, you can. And we brand that so we can actually wrap the trailer in your own practice if you actually get it. Again, COVID safe as well. Very easy for patients to have this and feel comfortable. Just some of our cases that we've had in our office. We've diagnosed narrow angle glaucoma, angle recession. We've actually diagnosed 2 retinal detachments, 2 new cases of wet macular degeneration, again, narrow angles. Again, we've diagnosed skin cancers and glaucoma. So it's really picking up all the major causes of vision loss. And billing, again, tele-eye care, tele-ophthalmology is now billable and reimbursable. Obviously, there's going to be some shifting as the pandemic changes. We don't know where that's all going to wash out, but we do know that tele-eye care is here to stay. The reimbursement is going to be here to stay in some form or fashion. And that's going to be a little bit of a moving target, but right now we know, and we've been reimbursed for full eye exams for the last 6 months using GlobeChek. So we're going to show you a brief video, and after that, we're going to have Dr. Aliswad give us her talk.
Welcome to GlobeChek, the future of tele-eye care. Our patented technology can complete an exam in less than 10 minutes without any dilation, touching of the eye, or eye drops of any kind. There are 11 tests that make up the testing package, and the quality of imaging is the same as the doctor's office. GlobeChek is effective for virtually all ages and is handicap accessible. Patients can pre-register on any mobile device, tablet, computer, or at a kiosk, and are notified when it's time for their testing by text. Once the exam is complete, the patients may leave. All tests are sent through a protected network to our reading center where the tests are interpreted by a GlobeChek certified doctor. A report is generated and sent to the patient. The patient then accesses their report through a HIPAA-compliant portal. They can then select their telemedicine video conference with the doctor to discuss their findings and recommendations. Our GlobeChek mobile office can take the exam anywhere, eliminating access to care issues. Large and small businesses, schools, long-term care facilities, and community centers are just a few of the limitless locations where GlobeChek can be deployed. GlobeChek, the future of eye care, is here now. Please contact us to schedule a demonstration.
Dr. Lemma Aliswad. She is currently professor of the Department of Ophthalmology at NYU. Grossman School of Medicine. She's Vice Chair for Innovation, the Department of Ophthalmology. She's board certified by the American Board of Ophthalmology back in 2005. She received her medical degree from Damascus University in 1993, completed a residency at SUNY Downstate Medical Center in ophthalmology in 2001, and then completed a fellowship under the tutelage of Peter Netland at the University of Tennessee in Memphis. She also has her master's in public health from Columbia University, circa 2015. So Lemma, take it away.
Thank you for inviting me and for this great presentation. I think GlobeChek has done a lot and paved the way for the future of telemedicine. So I'm going to just speak a little bit about teleophthalmology and the GlobeChek. These are my financial disclosures, and just to reiterate what Bill mentioned, that globally we have a burden of disease. 2.2 billion people have vision impairment and blindness. 1 billion of them could have been reversible, and the majority are refractive error, cataract, glaucoma, corneal opacity, diabetic retinopathy. So these are things that are there that we have to address. And as Bill mentioned, there's burden of disease and especially glaucoma in addition to diabetic retinopathy. I got involved in this because of glaucoma as a glaucoma specialist. And if you notice, 50 to 90% of populations around the world that have glaucoma don't know they have glaucoma. And this is why I started doing screening initially before telemedicine for ophthalmology. And I screened in New York City between 2006 and 2014, approximately 8,500 individuals. Of course, we had 25% screen positive, but the astonishing part was that 57% of them never saw an eye doctor in their lifetime, regardless of having insurance. And this is New York City, and partly because we screened high risk communities. So, what is telemedicine? And telemedicine in general, tele is a Greek word, means distance, and telemedicine refers to the practice of medicine at a spatial or temporal distance by exchanging medical information via electronic communication. And it could be just telephone calls, emails, in addition to virtual visits. And there are benefits. This is prior to COVID. In isolated communities and remote regions, sharing of information, decrease outpatient visit cost, and eliminate transmission of disease. And these are the benefits that were discussed prior to COVID. And of course, there are disadvantages: IT security, cost of data management, cost of setup has been shown during COVID. A lot of practices and hospitals were not ready for telemedicine. And of course, time efficiency. So, why teleophthalmology? And I'm going to re-stress what Bill mentioned. So, look at what we do in ophthalmology. We have heavy reliance on imaging, photos, OCT, and visual fields. And in my opinion, 90% of what we do diagnose, we could diagnose it with these modalities. Our patients are senior citizens with lower mobility. We can improve access to care to decrease the burden of blindness. As mentioned, 50 to 90% of individuals with glaucoma don't know they have glaucoma. As Bill mentioned, 25% of patients with diabetic retinopathy don't get evaluated. And I don't know if a lot of you know that diabetes is considered an epidemic. 1 out of 5 individuals in the US by 2030 will have diabetes, and partly due to obesity. It does expand access to care in general, and telemedicine could be used for remote training. So, how can you use teleophthalmology? I think we can use it for screening. I think we can use it for diagnosis, chronic disease management. So, yes, we can screen, but we can manage disease through telemedicine. And of course, we can educate. The idea of practicing outside the office is not new. Actually, George Halverson, the CEO of Kaiser, in the early 2000 mentioned start delivering healthcare further and further from the hospital setting and even outside the doctor's office. So people have been anticipating and predicting that we will need to deliver care outside the doctor's office, not even the hospital. And I got involved in telemedicine because of that, because when we screened, we noticed we found other ocular diseases, and there must be a better way of screening disease and creating a value, because screening for glaucoma has been controversial due to the value and the lack of follow-up of patients. So we built this teleophthalmology mobile unit in real time to screen for the four leading causes of blindness, which has visual acuity, tenometry, FDT, fundus photos, and we did other comorbidities. And our goal was at that time to increase awareness of eye disease, provide better access to care, reduce the morbidity from common eye conditions, decrease the burden of blindness, and improve models of telemedicine. And of course, trying to understand the matrix of eye disease in New York City. And between 2017 and 2018, we did a study screening 957 individuals, and the mobile unit went into different areas of New York City. And we noticed that 48% of them needed ophthalmic evaluations. 32% were glaucoma suspect. The astonishing part was the narrow angle, because the population that we screened, we didn't anticipate narrow angle with it, but it was 14%. Cataract was 13%. Diabetic retinopathy was 3%. Macular degeneration, partly because we screened Hispanics and African American. And our conclusion was mobile real-time teleophthalmology is both workable and effective in increasing access to care and identifying the the four leading causes of blindness. But that's not enough. So if you have a mobile unit that you can go from one place to another, that's great. But who has the ability to hire a driver, take a mobile unit, screen for disease, go from one place to another? The future is our kiosks. And I applaud Bill and Adam for coming up with this idea, because everywhere you go there's a kiosk, right? In the airport there's a kiosk. You manage yourself and what you need to do. In other places there are kiosks. So why isn't there a kiosk for ophthalmology? This is one. The patient should be able to get an eye exam whenever they want at their convenience. I personally say that if I have glaucoma and I have to go see my doctor 3 times a year, most probably I'll go blind, especially that I have to spend 2 to 3 hours in my doctor's office. A lot of our patients do spend 2 to 3 hours in the office. So Bill and Adam reached out to me when they built the GlobeChek, and we've discussed, and like-minded people. I got excited, and we wanted to trial the kiosk at Columbia when I was at Columbia. So we brought the kiosk to Columbia, and we put it in front of the emergency room. And basically, we wanted to do it for 3 months, and we wanted to 3 to 4 months, and we wanted to see how well do people accept it. Are we able to identify disease? Is it easy, and how long does it take? And are the patients appreciative when you do that? So we screened 326 individuals in 4 months. We didn't screen every day. We screened 4 days a week, and we screened 3 to 4 hours a day, depending. And we noticed that 50% of the participants had one eye condition. 14% had more than one eye condition, 21% glaucoma, 11% narrow angle, 1 to 2% diabetic retinopathy, and 1% macular degeneration. And there were other eye diseases that we noticed. Patients were so ecstatic, partly because we put it in front of the emergency room. So everybody who's waiting for their family members in the emergency room got their eyes checked. But astonishingly, they loved it so much that we had people come from New Jersey to get evaluated. And the way we reach our patients, because this is telemedicine, we actually send them emails with the results, because this was asynchronous. And we had them follow up in our practice or other practices to confirm the diagnosis. The astonishing part, each exam took 18 minutes. Whereas if you think about it, in my office, it takes 2 to 3 hours. And of course, they had a autorefraction, they had non-contact IOP, anterior segment imaging, posterior segment imaging, anterior segment OCT, and posterior segment OCT. And that's all in the kiosk. And I think patients too were fascinated because they felt it's the future and something they've never seen in the past. And we started getting calls after we closed. And when are we going to have it running again? Because they want to come and get evaluated, their family members. And if you look at what we noticed, the demographics, mostly the mean age for the people who wanted to use the kiosk were in their 50s, and ethnicities were mostly African American. And of course, we did an additional to what we said. We did hemoglobin A1C. We did certain questionnaires because of dental hygiene. As a lot of you know, there's an association between dental hygiene and the severity of glaucoma, smoking status, and when they've had an eye exam before. We compared the self-reported disease to newly detected disease, and you can see that newly detected disease had 27%, glaucoma 12%, narrow angle, diabetic retinopathy is close to 1%. So we did diagnose new disease. Or if you look at the different types of testing, as mentioned, we had intraocular pressure, visual acuity, we did central corneal thickness, cup to disc ratio, and of course OCT. And we did additional tests, which was the FDT. And we did follow patients to confirm disease, and we had high confirmation of disease. And this is our team that worked on the project. But in general, we need to think of what happened with COVID. So BC versus AC, in my opinion, instead of AD. So look at the publications of telemedicine pre-COVID. You barely can see 1 to 2 publications. By this year, we had 45 publications on telemedicine and teleophthalmology, the 45 publications. And if you look at the models pre-COVID, it was mostly the models were save and forward, the majority, video conferencing, synchronous, and a hybrid. And mostly it was used for screening, triage, patient consultation, provider to provider, remote supervision, and provision of comprehensive care. And this is all around the world. These are studies that have evaluated the use of telemedicine, and that's all pre-COVID. And as mentioned, diabetic retinopathy is the highest that usually uses telemedicine, and there's a need. And the ADA recommended high quality fundus images for photography and for asynchronous telediabetes. ROP is a very common disease for the use of telemedicine using the RetCam. Glaucoma is less, and of course, we have other teleeducation, telesurgery, and others. But what happened during COVID? We did not understand what was happening, right? It happened in March. I was in the center of the pandemic in New York City. We did not understand the disease. We did not understand safety for patients, staff, and doctors, what types of devices to use to protect ourselves. We had heavy reliance on imaging and technology. So how can we do telemedicine or virtual visits when we cannot evaluate the patient that well? Cross coverage for our staff. Are we going to expose all our staff when we see patients, or can we have one person deal with the patient? We didn't know the duration of the pandemic. We don't know when we'll reopen and what's called COVID casualty. Are we missing diseases? Are patients getting worse and we not able to monitor them? And in March 2020, the CMS temporarily basically lifted a lot of the restrictions and started paying for telemedicine. And one of the obstacles in the past for telemedicine was payment. And this all resolved. And not only that, they relaxed HIPAA. For people started using Zoom face-to-face without consequences. And if you look at the implication of the telehealth on the and post-pandemic, there was changes in payment, changes in privacy, as mentioned, changes in licensing. You could practice anywhere in the country. I literally saw virtually patients all around the country. And but we noticed what we have our limitations in general. We are not able to test vision. We are not able to evaluate beyond external photos, the ability to measure IOP, the ability to image the eye remotely, and chronic disease monitoring. Some of the solutions could be using an app, read eye care tonometry, practice extenders similar to the GlobeChek, and of virtual reality visual fields. So just an overview of what we did at NYU for virtual visits. What happened is the minute this happened, we had an amazing infrastructure in the institution, which is different than the majority of the institutions. So telemedicine has been used at NYU for a long time for virtual urgent care and for transplant monitoring patients post-op for certain fields. So we were able to literally within 3 days of to launch virtual ophthalmology. The institution prepared 2 weeks, and within 3 days, the whole institution, after the preparation, was able to launch it. And we looked at what's important during that, which is history is very important. We put guidelines, we put red flags, and we used vision cards to measure. We used the eye care tonometer, and we used virtual reality visual fields. And but on June 8th, we already have done 1,565 visits virtually. And of course, this is important to take care of patients. And again, remember, we have cost to our practices. So it was important to launch teleophthalmology and virtual visits. Other places try to do drive-through, try to do remote communication with the patient in different rooms to try to monitor patients. But the future has changed. The future totally changed, and there's no going back. The National Committee for Quality Assurance released a report a few weeks ago, basically saying that patient safety and program integrity concluded that the telehealth enhances patient care and it minimizes travel, although they also found some kind of fraud, but it could be handled and monitored. It determined that the quality is no different than face-to-face care. It's just a different modality for care, and they predicted that it decreases cost of healthcare. This is them reviewing 300 publications on telemedicine in general. And they concluded that this report gives some overreaching policy recommendations, suggesting that the following policy be made permanent after the pandemic. This is huge: lifting geographic restrictions and limitation on originated sites, allowing telehealth for various types of clinicians and conditioning, acknowledging, as many states now do, the telehealth visit can meet requirements for establishing a clinician-patient relationship for encounters, eliminate unnecessary restriction for telehealth. This is major. This is like, this is something that nobody has predicted that will push telehealth that fast and that much for the future. So in the future, we're going to use telehealth in the practice. We're going to use it as practice extenders. We're going to use it for home monitoring. Telemedicine is here to stay. It's going to stabilize in between. We like any new technology, initially no buy-in, then it reaches the peak, and then we will be will average, and not as many lack of restrictions, but we'll get there'll be some restrictions to it, but not what we were there before. COVID did accelerate the development and enhance teleophthalmology. New models of care are very important, similar to the GlobeChek. There will be new models of care. We will be utilizing it. And in reality, this will help our patients. And this will push to develop new devices for home monitoring. Thank you.
All right, we ready? Yep. Okay. Lemon, that was a fantastic talk. We really appreciate it. We think back to the first time we met you, and you came over to that Globe at the Academy, and you were like, finally, somebody understands what I'm trying to get across to people. So when we think back now, that was what, 5 years ago? That was a great talk, and we are going to do questions and answers at the end, so please hang around. Bill, you're going to introduce our next.
Yes. So yeah, great talk. I echo that. That was fantastic, and it really catches the essence of what we've been talking about. And yeah, to think back when we first met, and then what was it? Almost 3 years ago, you had the World Teleophthalmology Conference at Columbia when we were up in New York talking about tele eye care and the shrinking office, and I don't think any of us could have imagined fast forwarding less than 3 years to see the changes that we had sort of envisioned going forward.
It was quite a prediction, because I remember, Lemmy, you told us what the title was going to be of the talk, and we were like, you sure you want us to use that?
The shrinking,
and it turned out to be exactly that.
Yeah. So our next speaker is going to be Dr. Chad Albright, who is a busy cataract surgeon at Vistar Eye Center up in Roanoke. I've known Chad for quite a few years, and I want to thank Chad for being the first doctor outside of Center for Advanced Eye Care to employ GlobeChek in his practice. I'm really looking forward to hearing your insights as to your experience so far with GlobeChek. I think we installed back in June up in Virginia, and again, please let us know what your experience has been so far.
Sure. Well, again, I'd like to thank you guys for asking me to join in tonight. So I've been in practice for about 21 years up in Roanoke, Virginia, and initially I was just kind of general ophthalmology, seeing patients mainly in Roanoke 5 days a week, and I did that for probably about the first 5 years, and then my practice expanded, and we really kind of put a footprint into Southwest Virginia. And over the course of the last 15 years, I now spend most of my time going to our satellite offices, just seeing cataract evaluations. And this left a bit of a void for me in Roanoke. I had a lot of patients that identified me as their ophthalmologist, wanted to continue to see me, but my hours in Roanoke were shrinking, and now I spend most of my time, as I said, on the road and in the operating room. So we installed our GlobeChek just at the very beginning of July, and I'm in a group with about 16 other ophthalmologists, and we initially were going to test this out on my patients that were waiting a year or so to see me, and so we went through the schedule and picked out diabetic patients who were stable, bilateral pseudophakic, epiretinal membranes, drusen that were stable, and we offered them GlobeChek exams, and people just jumped on it. They thought it was very advantageous to have their appointment moved up. They didn't have to be dilated. They were going to spend 20 minutes in our clinic, and then they were going to still get to talk to me through a video chat. And amazingly enough, most of them feel like they're still their doctor. They always comment that they're so happy that they can still see me, that they can still talk to me, even though these chats last, anywhere between 2 or 3 minutes. They really are happy that they get to hear my voice and know that I'm still looking at their eyes. So we've been doing anywhere between 5 to 10 patients a day. I have one of my technicians stay behind. She's been running the Globe really exclusively for the past 4 months, and I see patients in between my patients in the satellite offices. If the patient doesn't have video access on their phone, then we have set up an iPad right next to the Globe, and my technician texts me and lets me know somebody's ready. I review their GlobeChek report at whatever office I am or in between cataract surgeries. I then call our iPad, talk to the patient, do their exam, And then the patients that do have video access at home, I use my time when I get done with work to talk to them. So just today was a typical day. I was in the OR all day. We did 6 or 7 GlobeChek exams. I did them in between our cases, and we have about a 6-minute turnover in our OR. So it's not like we have an hour in between patients or in between cataracts. So it works out very efficiently, and you feel good at the end of the day. You feel like you've maximized all your time. It's a bonus in terms of being able to bill these patients, and we've been getting reimbursed by insurance. They've been paying for the exam. They've been paying for the studies, and it's been great. I told a funny story to Bill and Adam back in August. My wife and I dropped my daughter off in college and took a trip out west in our Sprinter van, and we were in Jackson, Wyoming, and we had pulled off at a rest stop, and we were looking at the Tetons, and my technician texted me and said that she had a husband and wife that did not have iPhones, and so I had my laptop with me. I brought up their GlobeChek exam. I did the review. I brought up their EMR, did the review, and then I called them. And instead of actually me sitting there talking to them with my face, I just flipped the screen and said, I'm at a rest stop looking at the Tetons. Why don't you guys enjoy the view also? And they just thought it was the greatest thing. So the patients have loved it. They have all kinds of space age names for the globe, and even the older patients that really aren't technologically savvy really have nothing but positive things to say about it. The fact that they don't have to wait, there's no dilation. All of them have asked to do it again for their follow-up exams. If we do see something that's out of the ordinary, we just bring them in, and I just do a regular eye exam on them. So it's been great, and I think the future growth potential for this is amazing. We haven't really even rolled this out into my practice yet. It's just still being used on my patients, and we really haven't used it as a screening device yet either. So I do think that the application for this really is about as as creative as you can get with it. But yeah, it's been very, very helpful to my practice, and for me to feel like I'm still maintaining a doctor-patient relationship and having my patients still feel like I'm the one that's doing all their exams. So I think the best way to probably handle the rest of this talk is really question and answer, because I'm sure you guys have a lot of questions about kind of just how the whole process works.
Chad, that was great.
Yeah, we appreciate you sharing your experience with us. You're out there using the machine, so that's really helpful. So yeah, I think we'll turn it over to some questions and answers from the audience.
So we do have some questions that have come through, and
yeah. So the first question, somebody asked, is there any similar instrument out there that I can do what GlobeChek does? And the pretty much simple answer is no. What we like about GlobeChek is that we're able to put all those pieces together, as Bill mentioned. So there are companies, of course, that make the individual instruments. There are pieces of fundus photography that people use over time. But what we've spent a lot of time on is just making it a turnkey solution. So, for instance, it all sort of just works. All of the results are sent to a reading center. The physician reads them. The report goes out. So the whole backbone has already been figured out. So to our knowledge, no. And we're quite amazed, because even when we first came up with this, as Bill was saying, we said, well, it's got to exist. I mean, we're not the only ones to think of this. But it turns out no one had, or at least no one had done it yet. And 6-7 years later, we don't really see any other company that's doing what we do. You want to take a look at that?
Yeah, so one of the others was, what are the new options or changes in GlobeChek 2020 compared to the 2019 version? Most of the changes that we've had a few physical changes to the actual globe. We've been able to make some modifications that allow our globe to go through a 3-foot door. I would say probably from a physical standpoint, that's probably the biggest thing that we've done. We've made some modifications to the shell, which make it a little more durable, a little easier to access. The patient opening, that we actually have a kind of a door that flips up, also has a kind of a curtain attached to that, which will actually create a little bit more of a darkness around the patient, a little more privacy, also allow the pupils to dilate a little bit. So we're getting a little better yield on our studies because we're able to do it and almost create a dark room for the patient. And as far as future versions, we're continuing to work on the user interface. We've had some significant changes in our user interface. This is more on the technical side for the technicians who are using it. It's much easier to use. It's much faster. We're working with some of the product device companies that we work with to create easier access and easier user interface just to speed the exam. We think ultimately we can get the exams down to 5 to 7 minutes.
Next question asks, do we need a certified tech to operate GlobeChek? So good question. No is the simple answer. We specifically designed the Globe to be, as Bill likes to say, to learn how to operate the Globe. 5 minutes, fifth grader. So maybe exaggerating a little bit, but the interface that runs the Globe, we've made that as foolproof as possible. So it doesn't require a doctor, obviously. It doesn't require a COA, COMT. So someone can be trained how to use the machine, and we just had our big Salesforce meeting, and basically they watched one, they did one, and they taught one. So we took that in for both a financial reason, if we're paying someone by the hour and we're paying a COA or a COMT, certified ophthalmic assistant, obviously that's going to cut into the financial side. So the simple answer is no, you need someone to be trained.
And again, training someone quickly allows us, we think a lot of utilization of GlobeChek is going to be in emergency rooms where there is a lack of eye care coverage. If you look at emergency rooms throughout the country, there is really a lack of eye care being delivered in these places. And this is a perfect solution in an emergency room setting to evaluate patients. You can have ophthalmologists from anywhere around, actually, miles away, states away, being available to read these scans and triaging these patients in the middle of the night. And that's a huge cost savings to hospitals who, without eye care, are forced many times to send patients to different locations. We had a local one where subconjunctival hemorrhage was sent to 2 different hospitals. Patient had a CAT scan, was traveling sent by ambulance. I mean, tens of thousands of dollars spent on a patient with a subconjunctival hemorrhage, which could have been easily taken care of.
Next question says, can I take the Globe to different places, or is it in my office the entire time? So from day one, this was designed as a mobile Globe. You can absolutely take it to places. So by way of the trailer, which we can bring it to a business. Locally, we have Piper. We can pull up there. We can take it out of the mobile trailer, and we can bring it into their office and screen people. Or we can leave it in the trailer, and people can come in the mobile office and get scanned. What's nice about it is it plugs into any outlet. We have a generator, so theoretically you could be in a parking lot, turn on the generator, and you could be screening people, which we've done before, all day. It's designed, it can be moved by one person. It's on wheels, of course. It can be taken from room to room within an office. So absolutely, to move it around makes complete sense, and that's how it's designed.
Any plan to integrate AI for screening similar to IDX? Absolutely. The issue with AI right now is just the limited approval. So you have IDX, which got approval for diabetic retinopathy, but again, that's such a narrow scope. We ultimately believe that AI will do the entire eye exam, and you'll get instantaneous reads for the patients. And we've talked to most of the AI companies around the world that are very interested. Obviously, the data that we will be able to generate from doing all the GlobeCheks will go a long way towards developing all the nomograms that will be helpful for screening not only for diabetic retinopathy, but macular degeneration, glaucoma, refractive errors, you name it. And really, ultimately, artificial intelligence is going to drive this and be more accurate than physicians who are doing the readings.
Yeah. One of the questions is, will GlobeChek work outside of the U.S.? Again, absolutely. It was designed that way. We went to our first meeting. We actually had more interest from out of the U.S. than in the U.S. Obviously, there are remote areas outside the U.S. as well as the U.S. that need care and they're not getting the care. So we've had a lot of interest from people who want to take it into areas and provide eye care. A common model today is a clinic will send out a group of doctors, or a bus actually, bring everyone back to the clinic and then sort of treat the people who needed to be treated. In our model, you would bring the globe out, screen everybody, and only take the people back to the clinic to be treated. So it's compatible with different outlets. It's translatable, like the reading center, to different languages. So yeah, absolutely, we see it going everywhere.
Mm-hmm. Will it be in Jacksonville? When will it be in Jacksonville? Doctor, as soon as you want to see one up in Jacksonville, we'll bring it up to you.
Okay, so I think we have time for at least one more. Let's see, do we have another one? So for glasses, you know, what we, someone asked about glasses. So what we do is, as we mentioned, is we do an auto refraction, which is an approximate prescription, not an actual prescription. So the model there would be that people, and there's what, 20 million uncorrected myopes in this country, they would get their GlobeChek scan, they would find out that they need glasses, and then they would go to the appropriate eye care provider, either an optometrist or an ophthalmologist, to get the glasses. So we don't actually print a prescription, but we let people know that that's what the problem is. So for instance, if someone has diabetes and they need to be screened because they have decreased vision, then we do a scan and we say, no, you don't have diabetic retinopathy, but what you need is a pair of glasses. So.
Yeah, and we're, along that vein, what we're doing in Vero Beach, we're actually going to be at the health department. If not for COVID, we would have been doing the eye care for the health department here. And we do have basically what's called We Care, and there's probably different variations in different communities around the country. But we provide free eye care for those who need it from the health department, who don't have insurance, who fall between the cracks. And so the AR will at least result in us knowing those patients that need care, and we'll be sending those patients around the community for the doctors that volunteer for We Care, our office included. And those patients would then come in here for a refraction if they just needed glasses, and we would provide that for them. We also have a foundation, the GlobeChek Foundation, that's designed to reach out and do free eye care for those who can't afford it. So the GlobeChek Foundation hopefully will be covering most of the costs associated with delivering the eye care to the underserved, at least in our community.
Just real quick, I don't know if you can hear me, but what we've been doing is if somebody asks for a glasses prescription, my technician right at the end of the exam just brings them right into the exam lane, refracts them real quick, and writes the prescription. It takes 2 or 3 minutes right afterwards. So we've been able to do that, and the AR is actually pretty close. That she doesn't really have to deviate too far from that.
You know, along that vein, Chad, we've been working with a couple different companies who have refracting technology that allows the patient to get a refraction that is actually usable. So in places like Indian reservations, where we see a lot of utility for something like GlobeChek, they may be, I think in South Dakota, I think they have one optometrist who covers about 25,000 patients. And this is over an entire area of the tribal areas, many hours separating this. So they're really not getting a lot of care. And so in places like that, where we may be able to provide a refractive technology where they can come off the globe, put the AR into the refracting device, and actually get a prescribable prescription, that's going to have a lot of utility in some really underserved areas where they just don't have access to anything.
All right. Well, we want to thank everyone for joining us in the webinar. Lemma and Chad, and
Thank you. Thanks, everybody,
for joining us.